Welcome everybody to Friday, April 4th and my weekly Q&A live from my office. It is hot in DC. I hope you're comfortable where you are. And today we're going to be talking about prediabetes, metabolic health, insulin. What is the deal with Ozempic? What is the deal with all of the GLP-1 medications? What is metformin? And how to talk about metabolic health without centering numbers like the number on the scale, but rather centering the patient that we're talking about. Maybe that's you. So I wrote a post this week about prediabetes. And the reason I wrote a post about prediabetes is because it is a common word that is thrown around in the media, in doctors' offices, and it's often a word that people read when they are looking at their own lab results. They're looking at their own lab results more and more because you get your own lab results on the LabCorp or Quest portal. People look at these numbers and they think they have prediabetes, and they may actually have something that is akin to prediabetes, but I want to define it. I want to talk about what it actually is, and I want to answer your question. So feel free to shoot questions at me as we're talking. I will acknowledge that reading the questions on Substack is a little tricky, so if I don't see your question, write it again. Okay, so what is prediabetes? Prediabetes, to me, is not actually a great term. Um, Prediabetes is the medical establishments or LabCorp or lab companies' attempt to label a metric. The metric that we're talking about is called the hemoglobin A1C. The hemoglobin A1C is a blood test. The hemoglobin A1C is a blood test. The hemoglobin A1C is a blood test that measures an average of your last 2 or 3 months worth of blood sugars. In other words, a hemoglobin A1C is able to look retrospectively at the last 60 to 90 days and tell us how high was the amount of sugar in your bloodstream. A hemoglobin A1C that is a hemoglobin A1C that is 6.5 or above is consistent with type 2 diabetes. I'll repeat that. A hemoglobin A1C of 6.5% or above is considered in the diabetes range. We don't diagnose someone with diabetes unless it's repeated and we have other evidence that there's diabetes. A normal hemoglobin A1C is 5.6 or below. So if you have a healthy metabolism, you're lucky enough to not have genetic predisposition towards diabetes, and your diet is relatively stable, and you have the constellation of reasons we'll talk about that allow you to have a normal hemoglobin A1C, that is 5.6 or below. The gray area is what I'm talking about. I'm talking about this gray area between type 2 diabetes, 6.5% A1C, and normal A1C, 5.6 or below. 5.7 to 6.4 hemoglobin A1C is what is often called prediabetes. The reason I don't like the word prediabetes is because it implies inevitability. It implies that if you have a hemoglobin A1C of 5.8, 6.1, or anywhere in that gray area, that you are inevitably heading towards diabetes. That because pre anything means to a lot of people that this is going to happen. This is my future. This is my destiny. When the point I want to make today is that indeed there are certain parts of our health that we cannot control. There are parts that we have to accept. There are parts of our genetics, there are elements of our age and life circumstances that we cannot change that we have to accept. But when it comes to prediabetes and diabetes and preventing the consequences of high blood sugars, there is a lot of agency you have. In other words, the use of the word prediabetes and the inevitability that it suggests can, in some cases, and has in many cases for my patients, sort of robbed people of the sense of agency over their metabolic health, their blood sugar, when actually there's a lot you can do to reduce your average blood sugar, like day to day, to reduce your hemoglobin A1C, which is the measure of the last 3 months worth of sugars, to reduce your chance of what's called prediabetes becoming actual diabetes, and to limit the consequences of having high blood sugars wherever they are on the continuum. So let's go back to the basics. What is diabetes anyway? So diabetes and so-called prediabetes, the sort of measures that don't meet criteria for diabetes, is a phenomenon where insulin, in the case of type 2 diabetes, where insulin is not working efficiently. let me back up even further. Type 1 diabetes is different than type 2 diabetes. Type 1 diabetes is a phenomenon where the insulin, the protein called insulin that is made in the pancreas, in the islet cells of the pancreas, is not made in sufficient amounts. So we all probably know, or maybe we have ourselves, type 1 diabetes. Type 1 diabetes is typically caused, typically has an onset in childhood. And type 1 diabetes is a phenomenon where you don't make enough insulin, or where the pancreatic islet cells, the factory that makes insulin, is not working. Type 1 diabetes is a different disease, although it, of course, has everything to do with blood sugars. But what I'm talking today about is type 2 diabetes. Type 2 diabetes is a phenomenon where your pancreas is making insulin. It may have made plenty of insulin your whole life. And in your adult years, the insulin isn't working as efficiently. So again, type 2 diabetes is a distinct animal from type 1 diabetes, although there are many similarities, and we could talk about those. Type 2 diabetes is where the insulin you're making from your pancreas, the hormone called insulin, the protein named insulin that is supposed to help you metabolize carbohydrate, isn't working efficiently. And because the insulin isn't working efficiently, you have blood sugar levels that are higher than is ideal. What's supposed to happen is when you consume carbohydrate, whether it's birthday cake or carbohydrate that comes from vegetables, that stimulates your pancreas to release insulin to then metabolize blood sugar. So carbohydrate in the bloodstream goes into your muscles and provides fuel for your body. When insulin isn't working efficiently, when it's not working efficiently, which is called insulin resistance, is when the insulin maybe gets released when you are triggering your digestive system with carbohydrate, but it doesn't work well. And so there's blood sugar that lingers in the bloodstream. And when sugar or glucose lingers in the bloodstream because it's not being absorbed into tissues as it's supposed to do, that's called insulin resistance. That's called high blood sugars because of insulin resistance. Insulin's not working well, so sugar, glucose is remaining or lingering in your bloodstream, and there's potential damages, as you probably know about, from high blood sugars, either in the moment or sustained over time. As you know, the consequences of type 2 diabetes can be pretty severe. Type 2 diabetes is in part responsible for heart disease, stroke, kidney issues, eye issues. I mean, every organ system is affected by high blood sugars. So when we're talking about type 2 diabetes, as again defined by a hemoglobin A1C of 6.5 or above and repeatedly, or we're talking about blood sugars that are high but not in the diabetes criteria, like a hemoglobin A1C of 5.8 or 6.1, we're just talking about a continuum. We're talking about sugar levels that are in your bloodstream all the time and that are being measured by this single blood test, by a snapshot when you get your blood drawn, but that do reflect the average blood sugar over the last 3 months. So any amount of excess sugar in the bloodstream isn't good. The higher the blood sugar, the less ideal that is, and the more risk you have for having consequences of high blood sugars. And certainly, if you're type 2 diabetic and it's not controlled with medication and lifestyle, you're at higher risk for all the complications of diabetes type 2. So, does that make sense? Do people have questions so far about what is insulin? What is insulin resistance? What is a glucose level? Glucose and sugar are synonymous in my world. Um, and remember, you can have blood sugar elevations. Your blood sugar can spike appropriately when you have either sweets or any food with carbohydrate in it, which is a lot of different foods. Your blood sugar can spike inappropriately if you have insulin in your body that's not working appropriately. The insulin is not effectively bringing the blood sugar from your digestive tract out of your bloodstream and into the tissues that it needs to put it into to fuel your body. So we talk a lot, you probably have heard a lot in the news about like metabolic syndrome, metabolic health, insulin resistance, insulin sensitivity. And just for definitions again, insulin sensitivity is when insulin's working effectively, working efficiently. Insulin works more efficiently when A, you have insulin, you're not a type 1 diabetic, and B, when you are using the levers that are under your control when possible to lower your blood sugars. So how do you reduce blood sugar? How would you, if you're at A1C, if you have an A1C of like, let's say 5.8% or 6.1%, I'm picking A1Cs in that sort of gray zone for a reason, because those are the patients who've been called pre-diabetic. And again, if you're just joining me right now, I pretty much reject the word pre-diabetes because it implies inevitability, when it's not an inevitability that you go from prediabetes to diabetes. In fact, the whole point of giving you these metrics is to impart knowledge and information and provide guidance so that you can actually use the levers you have under your control to try to reduce your average blood sugars and reduce your risk for developing diabetes and reduce the risk of developing complications of high blood sugar, diabetes or not. So, what are the things you can do that are under your control to reduce your average blood sugar, to reduce your hemoglobin A1C? So, you guys have all heard the memo, right, about exercise, right? Exercise is good for basically every organ system out there. It's good for everything from depression to dementia to diabetes prevention. So, exercise, of course, is not just exercise. Exercise is movement, it is taking the stairs instead of taking the elevator. It is walking. Walking is a wonderful, sustainable way to improve cardiovascular health and to improve metabolic health. So, metabolic health is improved. That is, insulin sensitivity is improved. That is, your hemoglobin A1C is likely to be improved if you are getting cardiovascular exercise most days of the week, if possible. Now, that's not possible for every single person. If you have a disability, if you are injured, if you don't have time, that's not always possible. But it is true, nonetheless, that getting cardiovascular exercise is excellent for metabolic health. Cardiovascular exercise actually helps insulin work more efficiently. And it also just moves carbohydrate. When you are exercising, you're asking your body to move blood sugar from your bloodstream into the tissues, into the muscles. That's literally how you're moving. Like right now, I'm sitting. My hands are moving a lot because I move my hands when I talk, but I am using carbohydrate right now because I'm moving. I'm not using my hands because I'm trying to burn sugar. I'm using my hands because I am a hand talker. But I'm just happen to be using my hands and just sitting here, being alive, having my eyes open and making some kind of sense, right? Requires gasoline, it requires fuel, and that's carbohydrate. I also just happen to eat lunch. Um, so my point is that that cardiovascular exercise is essential for metabolic health. Let's talk about other kinds of exercise. Strength exercises. So strength exercises help metabolic health. That doesn't always make sense to people. Why would weightlifting improve your blood sugar? Well, because the more muscle mass you carry on your frame, the more efficiently your insulin works. And again, insulin's that pancreas hormone that's released when you consume carbohydrate. The insulin is the hormone that is responsible for helping you process dietary carbohydrate and mobilize it into tissues for use. If you have more muscle mass on your frame, if you have more muscle weight on you, you have more efficient ability to mobilize carbohydrate. So it's not just going on a walk, it's not just going on a bike ride, it's not just taking the stairs, it's having strength on your body. It's doing the curls while you're watching, White Lotus, or you're watching the news. God forbid you watch the news these days. It's doing some wall sits while you're, on the phone with Verizon waiting to figure out why your bill was all messed up. It is wearing a weighted vest when you walk. I have not done this yet. I'm a real walker, but a lot of my patients love using weighted vests if they use exercise, if they use walking for exercise. A weighted vest is something you can buy at, like, of course, Amazon, but you can get it at like some sporting goods store. And it's a way to supercharge your walking. It's also a way to get strength exercise and cardio together. So when you wear a weighted vest, you're adding weight to your trunk. And then you're asking more of your lower body, but also your upper body in terms of strength building. So that's another way to get strength work. Okay, so we already talked about the ways to improve your metabolic health, to improve your insulin sensitivity, to improve your glycemic control, your blood sugar control, and your A1C. And that is number one, exercise, cardio, strength. Number two is diet. Like, you've also gotten the memo about diet, memo about diet. Like, no doctor can finish a sentence without saying, like, diet and exercise, diet and exercise. There's much more nuance to it than just diet. So when we're talking about how to improve blood sugar, metabolic health, glycemic control, hemoglobin A1C as ways to protect yourself from developing diabetes. Or if you have diabetes, to lower your A1C and optimize your health. We're talking about diet and exercise. Diet meaning try as much as you can to limit simple sugars and try instead to consume carbohydrates that are more complex. So, what are simple sugars? Sugar, like table sugar, white bread, cereal, potatoes, I mean, baked goods. So, bread, rice, pasta, potatoes, cereal, alcohol. So, alcohol is a not all alcohol is carbohydrate, but wine and beer are basically carbohydrates. So, I have patients all the time tell me that they eat a really healthy breakfast: granola, yogurt, and raspberries. That is a healthy breakfast. And it's a sugar load. So granola is not bad for you because I don't think there's anything I don't think a food's as good or bad. Granola has high fiber, granola tastes good, and granola has, if it has raisins in it, it's got some fiber, it's got some oats, right? That's good for you. But it's highly carbohydrate rich. Yogurt, also good for you. It's got calcium, it's got protein, especially if you have Greek yogurt, but it's got carbohydrates. And then berries have carbohydrates too. Patients ask me all the time, should I stop eating fruit? Should I stop having granola? Should I stop having yogurt? The answer is, I'm not an absolutist. First of all, you can eat whatever you want. I'm just telling you that if you're trying to reduce your blood sugar, reduce your chance of developing type 2 diabetes or prediabetes, then you may want to pick a different breakfast that doesn't spike your blood sugar, like granola, cereal, yogurt, and berries altogether. For example, a good breakfast, I shouldn't say good because I just told you I don't like talking about food as good or bad, but a low sugar breakfast would be something like scrambled eggs, an omelet, some like grainy bread that's more complex carbohydrate with like almond butter or peanut butter. Um, Apples and peanut butter. As you can tell, I love peanut butter. I talk about peanut butter all the time. The point is that there's no right way to eat. I've talked about this extensively in my Substack, but there are ways to eat healthfully and to nourish your body and to experience satiety, which is an important part of our mental health and our physical health, and try to reduce your A1C, your diabetes markers, and to prevent progression from prediabetes to diabetes, which is again not inevitable. So if you're going to pick a breakfast and your goal is to reduce your blood sugars, I might steer away from the yogurt, granola, raspberries towards the eggs and the peanut butter with and some other low glycemic sugar. I mean, sorry, so some other low glycemic breakfast. Um, the other very common reason people have high blood sugars is alcohol. I've written about alcohol a ton. I think about alcohol a lot in my own life because alcohol is ubiquitous, it's socially acceptable, it's legal, and it's carbohydrate. So if you're trying to manage your blood sugars and you're trying to get your insulin to work more efficiently and you're trying to bring that A1C down, limiting alcohol is going to be a fantastic investment in your metabolic health. It may not be any fun. It may not be what you want to do. But when we're talking about how to manage blood sugars, I say that to my patients all the time. There are no solutions here, there are only trade offs. You might, for example, want to keep your breakfast granola and raspberries and yogurt and just skip the glass of wine at night. You're probably reducing your total blood sugar by a lot by doing that. If you changed your granola yogurt berries breakfast to, you know, eggs even 3 times a week and dropped the wine and kept it on the weekends only, that would be a lot less sugar you're consuming. And when you consume less sugar and you have less sugar in your bloodstream, even if your insulin isn't working terribly well, you just have less sugar to process. So that is another way to reduce your blood sugar. So number one is exercise and is strength cardio. Number two is diet. And it's not just reducing carbohydrates in your diet, it's also increasing your fiber intake. The more fiber you consume, the better you process carbohydrate and the less carbohydrate you have in your bloodstream. Fiber meaning oatmeal, which is carbohydrate, but it's complex. Vegetables are great ways of getting fiber. And sometimes I recommend to people who have like constipation, are bloating and high blood sugars, I'll recommend like a daily fiber supplement, like a Metamucil or a Benefiber, which can help with a whole lot of things from digestive health to cholesterol management to glycemic control. Okay, so we talked about diet, we talked about exercise. What about BMI and weight? So it is true that having extra adipose tissue on you and having low muscle mass can contribute to the risk factors for diabetes and for having a high sugar that's not yet in the diabetes range. Again, diabetes is A1C of 6.5 or above. A normal A1C is 5.6 or below, and that gray zone is 5.7 to 6.4, which is what we're talking about right now. So, weight management is important. And we don't, as a doctor, I don't center the number on the scale as the endpoint. It's not that I don't care about someone's weight. Of course, I care about someone's weight. I look at weight as one piece of the puzzle here. I have patients whose BMI is higher than is ideal based on the BMI scale, who have perfectly normal metabolic health. They have a normal hemoglobin A1C, they have normal LDL and HDL cholesterols, their blood pressure is normal, they're exercising, they're eating healthy. There's no reason they need to lose weight just to say they did, unless they wanted to, which is up to them, right? I have patients who are in the normal BMI scale, who have a normal BMI, body mass index, who have A1Cs that are higher than is ideal, even prediabetes, and have metabolic issues stemming from either diet or exercise, lack of exercise, or from genetics or from age, or just because they have insulin resistance for whatever reason. So the point is that weight matters, but what matters more is what are the metabolic markers we're looking at, including hemoglobin A1C. And am I, as a doctor, appropriately arming the patient with tools and information to manage the parts of their health that they have control over, which for a lot of people, they have control. Again, this is why I don't like the word prediabetes because it implies inevitability. We talked about exercise, we talked about eating, we talked about weight management, which is done, managing one's weight is in part with the things I just went over. Prioritizing strength work, prioritizing exercise, and prioritizing nutritious eating. It's not uncommon for me to have a patient whose A1C is elevated in the prediabetes range, who's eating too little. I talked about this last week, I think, or the week before. Eating too little is also not good for metabolic health. If you are someone who has a breakfast and then eats very little during the day and then consumes most of your calories between like 5 and 10 p.m., that also is not great for your metabolic health. Your metabolism may be saying, hold on, cowboy, I need some lunch in order to function efficiently. So sometimes patients don't need like a diet, they just need to have lunch. Sitting and eating lunch, high protein, low carbohydrate if you're trying to reduce your blood sugars, vegetables, protein, and then feeling satiety is going to help you not grab all the crap in your cupboard when you get home from work or wherever you've been at 5 o'clock. And feeling satiated in the middle of the day is also good for your mental health. So you're not feeling dysregulated and overeating at night, which is not good for your metabolic health either. So those are some simple tricks. If you want to talk about medications, we can do that now. People can ask questions. Feel free to ask questions as much as you want. So like I said, prediabetes I don't love because it implies inevitability. There's nothing inevitable about prediabetes becoming diabetes. And there are people who, despite their best efforts, go from prediabetes to type 2 diabetes. Blood sugar regulation and metabolic health are informed by some elements of our lives we can't control: age, genetics, lifestyle. For example, if you don't have time to exercise and you don't have time to chop broccoli and eat nutritious foods, and you have a genetic predisposition towards type 2 diabetes, there may not be a whole lot you can do. But I still believe there's always some agency. People always have agency. Reducing stress can help your blood sugar control. So when we're under stress, like many of you may be right now, I mean, I live in Washington, D.C., in the hometown of chaos right now. There's a lot of stress going around. When stress is at play, when people are feeling scared and uncertain and vulnerable, guess what happens? Our stress hormones get dumped into our veins. It's a lot like the March 2020 time in the pandemic right here in DC, where people are losing jobs, feeling undone. And so as a result, there's a lot of cortisol in people's bloodstreams. What does cortisol do? Well, cortisol is the stress hormone that allows us to run from danger. It's also the hormone that dumps blood sugar into our blood vessels. It mobilizes blood sugar from our tissue into our bloodstream. So if you're under sustained stress, you can actually have high blood sugars. This is just human physiology. So one of the ways you can help yourself manage metabolic health is the exercise we talked about earlier. It's the eating hacks and tricks we talked about earlier, and it's managing stress. Easier said than done. If managing stress was as simple as me saying, "Hey, just manage your stress," then that would be really easy. Someone's writing in here. A doctor recently put me on a CGM. We were worried about insulin resistance, but after 2 weeks, I'm rarely experiencing blood sugar spikes. Instead, I'm pretty regularly, 3 to 4 times a day, 5 times a night, experiencing blood sugar drops. I'm lost. This is an excellent point. I have probably a dozen patients who have high hemoglobin A1Cs. I'm going to say a dozen, maybe more, who have high hemoglobin A1Cs. They're not in the diabetes range, 6.5 or above, and they're not normal, 5.6 or below. They're in that gray area that I wrote about this week. So the assumption we're making is that when their A1C comes back from the lab repeatedly over years in the 5.8, 6.1 range, we're like, your blood sugars seem to be elevated. And it doesn't make sense because these are people who are lean, who eat lots of protein, very little carbohydrate, exercise regularly. They don't have a family history of metabolic insufficiency, and it just isn't adding up. So those are the patients for whom I'm commonly recommending a CGM, a continuous glucose monitor. Why? The continuous glucose monitors are an implantable device. They're very easy to use. I'm not going to use one myself because I hate having like tech devices on my body if I can avoid it. Um, but people like these things. Even non-diabetics are using them, which is a separate subject. But if you're curious about what your blood sugar is doing during the course of the day, you could now commercially purchase one of these CGMs, continuous glucose monitors. It is an implantable device you pop into your bicep. And what's cool about it is that it connects to your phone or connects to your computer, and it will tell you at any second of the day what your sugar is doing, how much glucose sugar is circulating in your bloodstream. And so the patients I'm talking about who have that A1C that's right in the middle range, that gray zone, not diabetic, not normal, are the patients for whom I'm recommending a CGM. Because for one thing, the hemoglobin A1C may just be wrong. It's a blood test, and there are many, many factors that can inform blood tests. So before I believe a blood test, it has to make sense. It has to make sense given the person I'm talking to. And sometimes I have found that when this person puts on a continuous glucose monitor, or they just do the old fashioned finger prick and they check their sugar, do one off testing, we learn that indeed their sugars are high. Their sugars are higher than is ideal. The spot sugar, the momentary sugar is actually higher than it should be. And it then makes sense that the hemoglobin A1C is high. The hemoglobin A1C measures a 90-day batch of sugars. There are patients, however, like you, who use the CGM and they find their sugars are normal, even low. And we're like, what the heck? This doesn't make sense. If the hemoglobin A1C is supposed to measure the 3 months worth of blood sugars, but your absolute blood sugar levels, the ones where you're putting a little catheter into your bicep, is telling you your sugars are normal, then that doesn't make sense. There's something wrong with the test. There's something about your physiology that is causing the hemoglobin A1C to be artificially high. And I'm not going to go into the details right now, but there are a couple phenomenon that can cause a hemoglobin A1C to be artificially high, like increased cell turnover, certain medications. I'm not going to go into major detail because it's uncommon, but it has not never happened. When your blood sugars are going low, if you're someone who has a CGM whose readings show that your blood sugars are low on average, then that just means you need to have more carbohydrate. You also need to see your doctor to find out, why are you going so low? Do you have an adenoma in your pancreas that's causing insulin to spurt out inappropriately? Um, you know, are you not eating enough carbohydrate? Are you doing intermittent fasting and that's causing harm? There are a number of reasons why people can have low blood sugars. And of course, our goal is you don't have enough energy or fuel in your body. Um, so that's a very good question, and I wish I had the answer for you, but I think it's a matter of connecting the dots between your CGM readings and your A1C. Okay, what were we talking about? Medications. So people ask me all the time, should I take metformin for my quote unquote prediabetes? Should I take Ozempic or Wegovy or Manjaro for my prediabetes? The answer is it depends. So the hemoglobin A1C, when it's in that gray area between 5.7 and 6.4%, which is often called prediabetes, means that your insulin is not working efficiently. Your insulin is not working efficiently to mobilize the sugar in your bloodstream into tissues. And that can be for a number of reasons: age, genetics, diet, absence of exercise, body mass index, body fat percentage, a whole host of reasons. Medications like metformin. Let's talk about metformin. Metformin is a medication that improves insulin sensitivity. Basically, it helps insulin work more efficiently. It's a wonderful drug. I love metformin. Arguably one of my favorite drugs on the market, if I had to pick. Metformin is a wonderful, wonderful drug. It helps insulin work more efficiently. So if someone takes metformin, whether it's for type 2 diabetes or for high sugars that don't meet criteria for type 2 diabetes, if you take metformin, you will see that over time, most likely, that your hemoglobin A1C goes down. Metformin isn't a panacea, it doesn't work on its own. It's best used when paired with the lifestyle modifications we already talked about. But let's say you didn't make any changes in your lifestyle and you kept drinking wine and having higher starch meals and you weren't able to exercise any more than you were. Metformin might reduce your A1C a bit. It might. It also might not. Importantly, metformin is not a weight loss drug. It doesn't really have anything to do with weight. It doesn't promote weight loss. It doesn't change appetite. And importantly, metformin can have side effects. It's usually GI side effects. The number one side effect is the limiting factor when we're trying to get a dose up in a patient, is diarrhea or GI distress. Metformin is an oral medication. It's a tablet. You start it at 500 milligrams at bedtime. Then you try to increase it to 1,000 milligrams, then go morning and night, aiming to get it up to 2,000 milligrams total, 1,000, 1,000. Of course, we dose the metformin based on the person, not just the A1C. And it is an effective way to help reduce average blood sugars. Doesn't do anything for weight. It also has anti-inflammatory properties. You've probably read some news headlines about metformin is going to, prevent Alzheimer's. Metformin is going to prevent dementia. But metformin is going to do X, Y, Z, ABC. I don't know if it's the medication alone or if it's the anti-inflammatory properties about that, but I don't think we have any cause and effect relationship clear yet between metformin and dementia. If I thought that metformin prevented dementia, I'd be taking it right now. But for now, suffice it to say that it is a tool in the toolkit to help with insulin efficiency. What about the GLP-1s? The GLP-1 medications are, of course, incredibly sophisticated tools that we now have in our arsenal to help with insulin resistance, to help with metabolic health, and to help people improve their blood sugar. Can you guys hear me? Like, this is saying my internet is unstable. Will someone hit a little button, like a smiley face, and tell me that you can hear me? Because it's saying my internet is unstable, but I think we're okay. Okay, someone just joined. I think we're okay. So we talked about metformin. Now I'm going to talk about the GLP-1 medication. So the GLP-1 medications, the Ozempic, Wegovy, Manjaro, and Zepbound, these are the new medications. Hello, Susan. These medications are the ones that are hot to trot. They're all over the news. They're all over the red carpet in Hollywood. And I will be honest, I've written about this. I think they are one of the most sophisticated technology that we've had in medicine in my lifetime, at least. And as I've written about extensively, the least interesting part about Ozempic and its cousins is the weight loss. That to me is the least interesting part. It's not that I don't think it's great that people lose weight who need to lose weight for their metabolic health. The most interesting part about the GLP-1 medications is their mechanism. What do I mean by that? The mechanism by which the GLP-1 medications work is that they help with a number of things. They help with insulin working more efficiently. That's amazing. They help with insulin working more efficiently. They also help with appetite. So people are less interested in eating the second half of the sandwich, getting seconds after dinner, and they're just less interested in alcohol too. They're finding that they're less interested in alcohol, which is of course a carbohydrate. The other interesting thing that I find the most fascinating part of the GLP-1s is their application for people's relationships with food. So the relationship with food for everyone is complex, right? I don't think there's anybody on the planet who just eats when they're hungry and then doesn't eat when they're not hungry. Like that is called a robot. Most people have an emotional relationship with food that's beyond hunger and satiety. And some people have a relationship with food that's even more complicated than that. Food provides comfort, food provides reward, food has more meaning than it might than that might be healthy. And so for my patients who are quote emotional eaters and or binge eaters, it's pretty extraordinary how Ozempic can help give people more sort of psychic or distance between the stimulus of seeing or thinking about food and eating and eating itself. So it is a day does not go by in my office where I don't talk to somebody who's on Ozempic or Manjaro who didn't even know they had emotional eating, who says, "Wow, not only have I lost a little bit of weight, but my relationship with food is improved because I'm not using it as reward or comfort. I'm just using it to fuel my body." Now, there are downsides of that too. There are downsides of that as well. You don't want to dose Ozempic. I never want to give a patient Ozempic for their metabolic health and then take away their hunger. Hunger is a normal human experience that should never be suppressed. In fact, disordered eating can itself suppress hunger. So you lose touch with hunger and satiety cues. So the goal of Ozempic is never to suppress hunger cues, but it's to calibrate hunger to the level of blood sugar and the needs, the energy needs of the human being. So what's cool about Ozempic and its ilk is that it helps with insulin efficiency. It helps with insulin's ability to process carbohydrate from food better. It helps with appetite, and it helps people feel more agency over their relationship with food if they had a problem with that in the first place. And then it also happens to help people lose weight, which for some people is important for their metabolic health. Having less adipose tissue on your body, if your adipose tissue is proportionally higher than is ideal, does help insulin work more efficiently. So those are the medications that are on the market. They're very popular. I think they're being overused, overprescribed in many cases, and I think they're probably being underprescribed in many cases as well. And that's true of every pharmacology item we have on the market, right? I mean, things are being abused and overused, and this is just the nature of pharmacology and human behavior. But the point is that for the appropriate patient, for the patient who understands that we're not centering a weight number or just an A1C, but rather we're centering the whole person, their metabolic health, and for the person who understands that Ozempic is not a substitute for healthy eating and getting exercise when you're able to in a sustainable, realistic way, and for the patients who understand that having extra weight on you is not a moral failure, but rather just is. Ozempic can be a really, really great tool in the toolbox without doing harm of potentially causing someone to lose too much weight, lose too much muscle mass, and then castrate them from their normal kind of hunger and satiety cues, which is not normal. The goal isn't to turn people into like robots who meet a certain BMI for the sake of you know not having a relationship with food at all and being thin. Like that is not the goal medically. So, what questions do you have about metabolic health, glycemic control, continuous glucose monitors, exercise, eating that we didn't talk about? And if you don't have any questions, I might just say to you that I'm super excited for next week. Joining me next week at this very time. Is that right? Yeah. Is my friend Sharon Malone. Sharon Malone, she was just on Oprah. But more importantly, she's my friend. Sharon Malone is a longtime friend of mine who's an OBGYN who's become a very outspoken advocate for women's health and for postmenopausal health and for hormone replacement therapy. She's not an evangelist for HRT. She's an evangelist for having a nuanced conversation about hormone replacement therapy. So next week at 3 p.m. Eastern, very same place right here, I will be talking to Sharon Malone on Substack Live about her book, which has just come out in paperback. It's called Grown Woman Talk. And Sharon's book is all about how to be your own best self advocate in the doctor's office. And for women how to have the conversation with your doctor about hormone replacement therapy, whether it's systemic hormone therapy or local vaginal estrogen for, hot flashes, night sweats, or for osteoporosis prevention, or for painful sex or UTI prevention. Women are entitled to conversations about their menopausal hormonal health. Not every woman should be on hormone replacement therapy, but every woman should be able to have a conversation about these topics. Um, and that's where we are. Okay, so now people are asking me some questions. Side effects, long-term use of GLP-1 drugs. So side effects of long-term use of GLP-1s. So believe it or not, the original um, incarnation of the GLP-1s has been around since 2005. So we actually have a ton of data on their long-term side effects. I mean, 2005 wasn't that long ago. My son is 21. He was born around then. So um, it's a long time. We have a lot of safety data on these medications. What I'm more concerned about, of course, I'm concerned about long-term safety, and we need more than 20 years to study these drugs. But what I'm more concerned about is the long-term implications of metabolic disease on heart health, brain health, vascular health. So I totally understand the question. It's a great one. And I would also say that the side effects of elevated blood sugars, elevated cholesterol, elevated um, poor insulin sensitivity are so real and known that and the side effects of the GLP-1s are so known that I don't worry as much about the long-term side effects. It's not to say I don't worry about them. It's just that and the other thing I'll say is this is a finer point. The patients who have, say, their BMI, they're 150 pounds overweight. They have had a near impossible time losing weight because of metabolic insufficiency, because of genetics, because of lifestyle, fixed realities of their lives. Those are the patients who stand to benefit the most from the GLP-1 medications. And I'm not saying that those are patients for whom we dismiss any concerns about long-term side effects, but the long-term side effects of a BMI over 40, high cholesterol, diabetes, or high blood sugars is so known that, and of course I talk to patients about the pros and cons and the trade-offs, that it's why I don't prescribe GLP-1s to everybody, because not everybody should be on a GLP-1. There are patients who want to lose 10 pounds to prevent prediabetes from becoming diabetes, and that's okay. But one of the reasons why it's not appropriate for everybody on the planet to be taking whose weight is like not ideal or perfect according to some metric is because medicines have side effects, and medications can have short-term and long-term side effects, and not all the long-term side effects are known. I hope that helps. What's the best way to protect muscle mass while using Ozempic? Two things: protein intake, protein with every single meal, breakfast, lunch, dinner, protein snack midday, and then strength work. So we talked about earlier in this program, we talked about strength exercises, doing like curls, wall sits, wearing a weighted vest when you're walking is a great way to supercharge your walking. But it's strength exercises. So doing like 20 or 30 minutes of strength work twice a week, or just in your everyday life, adding some strength exercises, yoga, Pilates. These are great ways to incorporate strength work, but protein and strength are key. I will point out that we were thinking for a while that the muscle loss from Ozempic was unique to Ozempic. In other words, we thought for a time that when people lost weight using Ozempic, that they were at specifically higher risk of muscle loss than they would be if they lost weight from some other way. It turns out that's not true. It is true that you will lose muscle mass when you lose weight. You will lose muscle mass and fat when you lose weight. Whether you lose weight with Weight Watchers, Jenny Craig, you know, brute force willpower, if you want to call it that, or with Ozempic, you will lose fat and muscle. It's just that Ozempic is so effective that people are seeing more muscle loss because Ozempic is one of the more effective ways to lose weight. So my point is, however you're losing weight, whether you're losing weight because you're on chemotherapy, or you're elderly and your appetite is low, or you're on Ozempic, it is essential to maintain strength and muscle mass by consuming protein and by doing some strength work. Um, are there any effective supplements to lower A1C? Yeah, berberine is an over the counter supplement that is thought to help with glycemic control. There are not great randomized controlled trials about it. I would say that better than berberine is to engage in some of the things I talked about in the very beginning of this program. Again, I started out by saying that I don't like the word prediabetes because it implies inevitability that you're going to become diabetic no matter what, which is not true. There are ways you can reduce your blood sugar control. So I would say there are ways you can reduce your risk for becoming diabetic, your blood sugars on average, and reduce your A1C. I wouldn't rely on berberine, even though, because the other thing is like, how does it work? It's one thing to make a lab number look prettier. It's another thing to have a mechanism of action that actually makes sense and improves your insulin sensitivity. I will be honest, I don't know enough about berberine to like poo-poo it. I would just say that the best way, the known ways to improve your glycemic control is not so much through berberine or supplements, but rather to reduce your glycemic um, intake, change your breakfast from granola and yogurt and fruit, which is healthy but high sugar, to scrambled eggs or apples and peanut butter, um, and to add some more muscle to your frame and to get a little more cardiovascular exercise. Take the stairs instead of the elevator, do all that jazz. It's springtime. Maybe you can get outside more. If you're lucky enough to have access to a gym, that could be cool too. Other people asking me questions. Hey, Debbie Weil, I saw you last week. I'm hungry about every 2 to 3 hours, and if I don't eat, I feel awful, nauseated. I try to get more protein to my diet, but I honestly get tired of eating. Well, Shelly, I hear you. Hunger is it maybe just your body telling you that you need to eat more. I mean, hunger is an adaptive cue that your energy needs are not being met. That may be true. Um, but it's frustrating to be hungry all the time for some people. I when I was a runner, I used to run a lot. It was like the way I stayed sane when I had three little kids. Um, and I was hungry all the time. And I ate. It was just annoying to have to eat all the time because it's like when you have to pee all the time, right? It's like if you're on an airplane, you have to pee. It's like you have to get up. And so being hungry all the time is annoying. The way to not be hungry all the time is to A, feed your body appropriately, and B, make sure you're feeding yourself with high protein, high fiber foods. So it's interesting to me, it's interesting to most people that eating carbohydrate, while it will instantly more readily quell hunger, it makes you hungrier faster. So in many cases, when people are hungry more than they think they should be, it's because they're eating more carbohydrate than they ought to. And that's just a thought. Um, what other questions? Craig Fuller, thanks. I'm having excellent results with Ozempic, but this is by far the best discussion I've heard. Craig, why don't you come and hang out more often? I will take that compliment. Yeah, again, like Ozempic it's in the news all the time. There are headlines all the time. And it's so fascinating to me how the headlines are so hyperbolic and so, I don't want to say they're wrong, but they're like not right either. People come in to see me all the time. They're like, I heard that you're going to get constipated and nauseated and end up in the hospital with like a bowel obstruction. Or they say, I've heard that you can never get off these medicines. Or I've heard that my muscle mass is going to waste away. I'm going to be frail and, die of starvation. And I'm like, oh my God, like there's so much hyperbole out there. The truth is that Ozempic is like many, many drugs we use in the pharmacopoeia. It's a tool in the toolkit. And while there are some people who go on Ozempic for type 2 diabetes who will want to stay on it for the long term, there are just as many people, in my experience and in what I'm reading, and it just makes intuitive sense after having seen patients for 25 years, who there are patients who will go on it, who will lose 20 pounds, improve their metabolic health, improve their glycemic control, have an improved relationship with food, and then who can taper off of it. Or take it instead of once a week, take it every 2 weeks, take it once a month, take it, for little stretches as tune-ups. There's no on-off switch with Ozempic. It's not like penicillin is to strep throat. You should take the full course of penicillin when you have strep throat. That's ideal because you don't want to have little bits of strep throat circulating in your bloodstream. But Ozempic is, it's like when someone has high blood pressure and I prescribe a blood pressure medication. I tell patients who have a high blood pressure, we diagnose it when someone has repeatedly high blood pressures and there's no underlying, obvious reason for it. So we call it hypertension, start you on medication, and then I arm people with the facts and information they need on how to reduce blood pressure if they're able to. Low salt diet, exercise, improving their metabolic health, limiting the booze, getting more sleep. And then sometimes we can pull the medication dose down when they've implemented the lifestyle modifications to lower blood pressure. Same thing with Ozempic. You can prescribe Ozempic. People can then feel maybe more motivated or satisfied with their own ability to exercise and eat healthy because they see their efforts paying off for the first time. This happens all the time. They're like, oh my God, I've been exercising and eating healthy my whole life. And finally, the weight's coming off. That's very gratifying. Most of my patients who have extra weight on them are not lazy or have bad willpower or uninformed about the harms of extra weight. They just haven't been able to lose weight. It's one of the hardest things to do. So, when people find they're able to lose weight and that their own efforts are paying off, it's uniquely empowering. And that is very cool to observe. I also am not going to participate with enabling patients who shouldn't be on Ozempic in perpetuity to meet some goal that is not about their health. If they want to do that on their own time and use some other drug company or compounder, that's fine. But I don't I think we have to use Ozempic as a medical tool in the appropriate context and understand that its ability to help people feel a little bit more agency over their health is about mental health, and it's about mental well-being, and it's about agency, which ultimately is the definition of health. So I'm writing this book. It's coming out next spring. And the book it's not about Ozempic, it's about health and redefining it as not just a set of metrics, as not just an end point, and certainly not about meeting a doctor's, commands or expectations. It's about you, it's about arming yourself with tools and information, it's about understanding trade-offs, it's about being honest with yourself about the limitations of your life and trying to accept the parts of your health you cannot control. And when we are able to accept the parts of our health that we can't control, which there are many, mortality is a big one, genetics, age, then we can lean into the parts of our health where we do have agency. And one of them happens to be metabolic health. We can't be metabolically healthy every single day, all day long. If you're going to go home and have a snack that's sweet and a glass of wine on a Friday night, that is good. That is okay. What I'm saying is that we can't have control all the time and we can't be perfect. The goal is to be, as I say all the time, a little more okay tomorrow than you are today, and that includes knowledge, information, and nuance. I hope that's helpful. Please join me next week to talk with my friend Sharon Malone, who's an OBGYN, who is a fierce advocate for women's health and hard conversations about menopause and hormone therapy. I will see you next week. Thanks for joining me.